And together, we will move mountains. And if they don't hear our message, then we'll just do it over and over and over and over 1,000 times again for you.
And I'll rise up, I'll rise like the day, I'll rise up in spite of you. I will rise, we will rise, we will rise, we will rise.
Hi, everyone. My name is Michelle Zabel, and I'm an Assistant Dean at the University of Maryland School of Social Work and Director at the Institute for Innovation and Implementation. As you all know, this year of working virtually has necessitated some really creative approaches to conferences. We've spread the training institutes out over the last 9 months, just a few workshops each month. And I just want to personally thank you for joining in these discussions. These workshops have been so much richer because of you sharing your experiences and ideas to meet the needs of children, youth, young adults, and their families. So today, I have the exciting opportunity to remind you of some general housekeeping items. Even in a virtual world, they don't let me out of this part. Our workshops are being recorded, and your participation does imply consent. Also, please remember, if at any time you need help in navigating through the virtual spaces or accessing the links to workshops, we have a live help desk chat that is being monitored during the duration of the entire workshop. Our team is posting the link to connect with the live help desk in the chat box now. During all the workshops being offered throughout this series, I really want to encourage you to actively participate by using the chat to post your questions, any comments, and any resources you want to share with your colleagues. Our presenters absolutely want to hear from you, and we know your participation makes the workshops even better. We have staff monitoring the chat in Zoom and on YouTube, and they'll be assisting with facilitating the questions to the presenters and making sure that the presenters' resources are shared with you. So finally, there'll be an ASL interpreter available throughout the workshops. Interpreters will be shown on your screen, and they can be pinned for those who require interpretation. So you want to hover over the video and select the 3 dots. One of the options that appears is pin video. So by selecting that pin video, this video will now not move out of view. This summer, we are continuing the training institutes in a way that will allow you to take us wherever you go. So hopefully you're getting to take a break, a vacation, and get some relaxation. We're recording our summer workshops and releasing them each month so you can watch them anytime during the month that actually works for you. These workshops are on a wide range of topics, all focused on strengthening your skills as you support youth and families. While you're enjoying these summer workshops, we're going to be planning and working towards future training institutes, and hopefully we can all see each other in person. Thank you so much. Take care and enjoy your summer.
Hello, and welcome to Integrating Effective Residential Interventions Within a System of Care. My name is Liz Manley, and I'm very happy to lead us off today with a great set of presenters, including Deborah Harberger from the Institute for Innovation and Implementation at the University of Maryland, where I also have the privilege of working, and Kathy Collins, the Executive Director for Monmouth Cares, a care management organization in New Jersey. Paul Rigger, the CEO of Bonnie Bray Residential Treatment Program within New Jersey's system of care, and Hazelyn Pilgrim, the Executive Director from the Family Support Organization in Essex County, also in New Jersey. I get to lead off this conversation today by talking about the role of oversight in residential best practices. I think it's really important that we spend some time thinking about what the role of organizations that have the opportunity to pay for these services for young people, but also have that added responsibility of ensuring that young people are provided the best care possible when a residential intervention is necessary. We consider these oversight agencies the payers, but they also have a responsibility for understanding best practices. So let's just talk about who they are. They include Medicaid in some instances, child welfare, juvenile justice, education, managed care organization, commercial payers, like private insurance companies. And private payers are individuals who might be paying out of pocket or using some other format or mechanism for paying for the service. We spent some time on thinking about who these payers are, because the idea of just paying for the service without having an understanding what it's designed to do, how it's designed to work, has really been detrimental to young people. And we're trying to really change the focus of what residential interventions are able to do in order to help young people really thrive in the future. So some strategies and tools for oversight, I think, are important to pay attention to. And I should just say that I have a particular interest in the role of oversight because I had the real privilege of being in oversight organization at the Department of Children and Families in New Jersey, where I was the assistant commissioner for a few years, where I had the opportunity to really think about and spend some time thinking about best practices. So some strategies and tools for oversight that I found helpful certainly in my time. And as I work providing technical assistance around the country, we talk a lot about these particular things as being necessary for coming to residential best practices. One is establish a culture of evidence. And that means not just in the residential interventions themselves, but really in the oversight agency. Come to that place where you are really working to understand what the best practices are. Do all the homework by talking to people who are providing service, people who are using the service, so that you can understand what's working, what's not working, what you need to think about changing. Establish the expectations for those residential interventions, including what you believe the outcomes will be. Setting some timeframes could be helpful, but really understanding what young people are, we expect that at the end of that time, what it's going to look like for them. We want to use best and promising practices, and that means, and we should have some clarity that there are very limited evidence-based practices that have been designed specifically within residential interventions, although you can include best practices, you can include some evidence-based practices in some of the work that are happening in residential. But we're looking at best and promising practices that get us to the outcomes that are really necessary. In that conversation, it's really important for us to think about and spend some time talking about coercive interventions and restraint and seclusion to ensure that the best practices that we're implementing are moving us away from those particular interventions. We want to implement policy and regulatory partnerships. So we want to work together to come to the best outcomes for young people. We want to develop and expand services and supports across the full continuum and make sure that we're using the full continuum as we're working with young people. We also want to invest in the workforce. And I think that if there's any one thing that we really need to do, it's the investment in the frontline workforce that is at every level within residential interventions, and for all of the partners who are going to work across the system of care to ensure that young people get the best experience across the full service. And by investing in the workforce, I mean providing frontline training that are going to give the frontline workers the tools that are necessary, but also coaching, mentoring, supervision, support at all levels. We need to make sure that that frontline workforce has everything that they need to ensure that that young person's experience is a positive one. We want to provide training and technical assistance. We want to use the best of the best to get the best interventions into what is the most costly part of any service array. And we want to generate support through strategic communication. In other words, we want to ensure that everyone knows what it is we're working on, how we're working to get there, and how we're going to partner to get to the long-term goal for our young folks. So creating a culture which is positive and productive means that we're basically saying that this residential intervention can be a positive experience and needs to be a positive experience for that young person. But in order to do it, all of the professionals and all of the adults in that child's life really need to come together to work together on what the game plan is going to be for that young person. We want to use contracting and the request for proposal to set the standards of where we want to go. And as a quick example, what I mean by that is in the RFP process, the request for proposal process within New Jersey system of care, we mirrored that in the contracting to set the baseline for what our expectations were for the staffing. In other words, for the workforce, the training that we anticipated the workforce would get, but also what staff we want to be at what table and how. We want to focus on transitions and aftercare, and we want to create a seamless way for those services to go into place, which is really complicated and takes time, but it's worthy to work on that. And you'll hear some of those ideas today in this workshop. We want to use continuous quality improvement approach and data to drive change. We really want to pay attention to the ongoing day-to-day, what's happening in our residential interventions, what's happening for our young folks. Can we see change over time? Are they achieving the goals that were set for them? Are they having a positive experience? And from my perspective, I just want to say, are those young people feeling better? And if they are, how do we know it? And how are they able to communicate that to us? We want to create or improve by using financial strategies. We really want to focus on making sure those residential interventions are the best that we can provide for our young folks. It's really important in a good and modern system of care that we're attentive to the highest cost service that we're going to provide. We want to make sure that we're going to provide it for the shortest period of time and have the most impact on that young person's life in the most positive of ways. So we want to also build partnerships, and those partnerships, those community partnerships, which you'll hear a bit about today, are just really essential in terms of changing practice. We want to pay attention to leadership and workforce and environment. The environment both in the residential intervention, but also creating that community environment across the full continuum by bringing language to a common element in which we're all speaking the same language, understand what our partners are doing and why they're doing it, and make sure that we are not duplicating services, that we're really effective and efficient in the work that we're doing. And then we have programming that works and makes sense, and that we're not using point systems because point systems are not really helpful for young folks. That the service is really family driven. And I just want to say, I really want it to be youth driven and family guided. We want family choice and family engagement strategies. We want to use family time and focus on maintaining and supporting family connections. Engagement is the number one thing we need to be focused on in the upfront work of getting young people ready for the experience of a residential intervention. That we want individualized planning and community strategies and connections. And that youth advisory boards or councils are really helpful in getting feedback to organizations around how they're doing and what the experiences are. It's also important to note that young people who are involved in interviewing processes at residential interventions have a real impact. They know who's going to do a good job. They know who they're not going to test and who's really in the work. They can tell right up front. So we want to use some of those instincts in order for us to move practice forward. Some best practices around building trauma-informed environments, which are really essential in this work. Start with creating environments that focus on dysregulation. And as soon as young people arrive, actually, from my perspective, I believe the work starts steps before, really a lot of steps before they ever touch into a residential intervention. In other words, we want to know and understand who that young person is, what their hopes and dreams are, and how we can help them achieve them. We want to create that environment that focuses on dysregulation by using things like sensory rooms and weighted blankets. We want to attend to the physical needs of our youth by making sure that they're fed and that they're able to sleep comfortably and that they're able to move around. We want to shift language, which is essential within systems of care work, so that we're all speaking the same language. And by all, I mean our young people speak the same language as the professionals who are serving them. We want to move away from the use of things like point systems and diagnoses as drivers. And what I mean by that is diagnosis is an important factor in some of this work. However, it's not the driver of who that young person is. And sometimes we put diagnoses on the table before we have clarity on even what's going on for that young person. So we don't want that diagnosis to be the descriptor for our young folks. We want their strengths, their hopes, and their dreams to be. We want to identify the behavior and the concern around that behavior in relation to safety so we can help our young folks understand what they can do. And we want to identify strategies around safety for youth as part of engagement. We use soothing plans for our folks that help us understand the young person's sensory diet. And we build a sensory box in which we can put tools in there for young folks to use during the course of their stay. Some best practices really pay attention to this idea of the sensory diet for our young folks, understanding the impact of sight, sound, smell, touch, taste, and in relation to traumatic experiences and how we need to understand each of those things for our young folks. It's really important for us to build in movement tools, such as yoga, and to use rocking chairs and stress balls for our young folks. In addition, we want to build community engagement strategies that allow our young folks to continue to be part of their own community, even when they're in a residential intervention. In other words, we want to bring the community to that residential intervention, or more likely, we want to bring the residential tools right into the family's home, which is really important within the context of this work. I'm going to hand to Deborah, who's going to share with us Marilyn's experience.
Good afternoon. Thanks, Liz. I'm Deborah Harberger, and as Liz said, I'm with the Institute for Innovation and Implementation at the School of Social Work. And we're going to take you on a little journey through Maryland and where we are right now. You know, you're going to hear a lot about New Jersey, and New Jersey's been doing this work for more than 20 years. And we all kind of want to be like New Jersey. And so it's important to hear about those of us who are not, and how we're going to get there. Maryland has a lot of strengths, a lot going for us. And so I'm going to talk a little bit about kind of where we are and where we're heading and where we hope to be. Liz, next. So I know I looked through the participants. I know some of you are from Maryland and many are not. So you're going to get a real quick Maryland 101. And really the purpose of this is so that when we start talking about residential interventions in Maryland and the reform initiative we're undergoing right now, you have a sense of why it's so complicated. We have a lot of different agencies that all do work in the space of kids and families. And we have a children's cabinet. It's one of the longest in the country since 1978, longest standing funded children's cabinet. And we have a lot of different agencies that have different types of responsibilities. And one of the things that this diagram shows you is that at the local level, we have a lot of variation in our structures, our system structures. And those of you who have done system of care work for a long time know the importance of system structures in doing any reform initiative. So we have, in some cases, 24, which is the number of counties plus Baltimore City we have. We have 24 jurisdictions in the state of Maryland. In other cases, we have regional offices. Sometimes we have 6, sometimes we have 4. Sometimes we have a relationship between the state agency and the local agency where the local is part of the state agency, like in our Department of Human Services and our Department of Juvenile Services. In other cases, there's a relationship between the two, but the local level is not employees of the state level. So that also plays a part when we look at systems reform and thinking about, you know, what is the role of the school system, local juvenile services, local child welfare, our local management boards, which are basically a convening body that look a little bit like the children's cabinet on the local level. There's a lot of variation, a lot of players. And so that's a piece to keep in mind. Next. The other part to know about Maryland is that we have a behavioral health carve out. So all children with Medicaid, whether it's CHIP premium, they're in state custody, they have a managed care organization, and then they have access to our full public mental health system, actually our public behavioral health system, that the Administrative Service Organization oversees and authorizes services under the public behavioral health system for all specialty behavioral health services. So that's consistent across the state, but it is a little bit different than other states, and the Administrative Service Organization does not authorize services outside of the public behavioral health system. So they're just doing that. So when we start talking about New Jersey and you see kind of the role of Perform Care and other agencies, it's different from Maryland and thinking about the structures that exist. So we have a robust public behavioral health system, but that's sort of in one segment of our structures. Next. So when we look at these structures and we start talking about residential interventions, each of these agencies, those state agencies we looked at before, have a role to play in different ways. So they're all members of the Children's Cabinet. We have an interagency rates committee that sets rates, and we'll talk about that in a moment. They're all members of our Quality Service Reform Initiative, which I'll talk about. But then whether they license homes, whether they contract for homes, how big that role is really varies by agency. So we don't have that kind of consistency, nor does it sit all in one agency. So it's a little bit of everything. Next. Okay, so we're going to take you on a little story here. Maryland's residential child care programs, otherwise known as group homes, are licensed primarily by the Department of Human Services, Child Welfare, with some by the other agencies. Different agencies contract for the beds. In 2011, the U.S. Department of Health and Human Services told Maryland that basically the Medicaid billing it was doing, they couldn't quite determine if it was in full compliance. And they recommended that the state review its residential rehab option that it was using to bill for group homes and treatment foster homes, and do some more defining additional documentation and maybe adjust its reimbursement methodology. So 2013, the Maryland General Assembly and then the Maryland Interagency Rates Committee recommended a new structure for these programs and a new rate structure. So in 2015, Maryland took it out of the Medicaid state plan and has been doing sort of preliminary work and fact finding and looking at other states and trying to figure out what this could look like. And then in 2018, the current Children's Quality Service Reform Initiative, which we call QSRI, begins. And so that's really kind of the start of this story. Next. So we know that really for more than a decade in Maryland, we've seen a steady reduction in the number of children in out-of-home placements, as well as those specifically in the group home placements. But we do still have kind of high numbers of kids in non-family settings. In child welfare, around 20% of all kids in foster care are in some sort of non-family setting, inclusive of psychiatric residential treatment facilities, PRTF, which in Maryland is the same as our RTCs. So at the end of February, there were a little over 500 children in group homes. The Department of Juvenile Services has actually seen a significant decline, including throughout COVID, and we've seen a decline in the number of youth in group homes and a pretty big decline in the number of youth of color in committed placements. So we're seeing some good progress, but we're not really there yet. We still have a lot of kids in family settings, non-family settings, sorry. Next. So what we learned in our initial fact finding in talking with local departments of social services, talking with providers, talking with folks at the state agencies, is that Maryland's placement process for how a child gets to a residential intervention is highly variable. It depends on, what bed might be available, who likes a particular provider, what kind of documentation came in, who responds faster, and it's really very variable. And so it's hard for anybody to really know who they serve well. It's hard for providers to be able to specialize because they end up serving children who come to them because the DSS calls and says, I need a bed for this child. We also don't have a consistent way to determine, does the child actually need a residential intervention? Do they need that level of care and treatment? Could they get what they need in a family setting? The current rate methodology that was referenced back in the 2011 report in 2013 and 2015 The rate methodology in Maryland is part of the problem in all of this. It goes back to 1999, and it hasn't changed since 1999. So everyone should stop and think about where they were in 1999, what they were wearing, what music they were listening to. That's where this comes from. It is not fundamentally a bad methodology. It has the right components. The challenge with it in 2021 is that it still uses an annual individual rate setting method. So every program has to submit an annual budget package for every program. And if a provider has multiple programs, they have to submit for each of those. And then there's a requirement that the state has to designate providers as preferred or non-preferred. They can adjust that, but it requires more layers of interaction and budget submissions and proposals and presentations. And then at the end of the day, it's all subject to the total availability of funding for the programs. So we have this highly variable placement process. We have a rate methodology that's very individual to a program and goes back to 1999. And we have structures that really support kind of a siloed approach. Even though we have a children's cabinet, even though we have local coordinating at the ground level, we still have a system that is relatively siloed when it comes to the issue of residential interventions. Next. So enter the Quality Service Reform Initiative, QSRI. These are the main prongs of what we are trying to achieve, and with the state agencies. This is in partnership with the state agencies for kids and families in Maryland. So it is a multi-pronged initiative where a core component is establishing consistent rates for both clinical and direct care services, establishing clear and transparent clinical and provider criteria for those residential interventions, consistent referral and enrollment pathways, getting the providers, the agencies, the communities, the families really ready to make this shift, because this is a big shift. Establishing performance measures and a CQI process. Liz talked about the importance of that. And right now, it just depends on the provider, what they do, and the individual agencies have different standards. And really making the shift so that we end up having better data being collected so that we can show who's getting what service, how are they doing, is anybody better off at the end of the day, and implementing a transition plan. We are working really hard to design the system we all want to have, and then we're going to create the transition plan that will bridge us from where we are now to where we want to be. What we don't want to do is design to meet today's needs. We want to design looking ahead to where we're going. Next. So right now, you're getting a sneak peek at the draft rate methodology. Draft, I'm going to just keep saying draft. But what it does is it takes that existing interagency rate committee framework, and it doesn't throw it out completely. It looks at the components of the framework, but it moves us away from individual rates based on individual costs. And we're going to be looking to establish direct care rates and clinical care rates, both to be bundled or comprehensive rates to cover the cost of care of these children. And that each program will have a bundled clinical care rate and a bundled direct care rate. And we anticipate that groups or programs are going to be bundled based on similar cost or characteristics. That doesn't mean that we won't have differences in who they serve well, but it means that they'll have similar operating costs. And that will enable us, hopefully, to be able to submit a Medicaid state plan amendment down the road for the clinical care rate, because that meets what the federal government told us several years back, which is you've got to be really specific about which services you cover, and you can only cover the clinical rehabilitative services. So by creating a clinical care rate, we get that done. So this will enable providers to know exactly what they're going to get paid to do. And then it will let them be more specific about who they serve and who they serve well, which is really to the benefit of the entire system, primarily for youth and families. Next. So this is even more drafty, but this is giving you a sense of what we're looking at. And when we look at our continuum, we know that generally when we talk about residential interventions, we are including psychiatric residential treatment facilities and even psychiatric inpatient hospitalizations. But for the purpose of Maryland, we're actually keeping a tighter construct for residential interventions. And we're thinking about it in phases. So the first phase are these group home residential interventions. A future phase in the next couple of years is going to be taking a look at how our rates are put together for treatment foster care. And then actually doing a little bit around our non-residential evidence-based practices. But this starts getting to the idea of having these classes, and you can start understanding how two different providers who serve two different populations of kids could have the same rate in the same class. The best example I can give is that you could have a provider who is in class 2, who does a really great job serving youth who have a lot of aggressive behaviors and maybe need a lot of supervision, might have the same rate as a provider who serves youth with intellectual or developmental disabilities and also need a lot of supervision and high level of qualifications of the staff. So that's where we are right now. And we're moving through that, creating medical necessity criteria, service descriptions, provider qualifications for each of these classes. Next. So we're really trying to break the link between placement and services and get folks to think about only having a child experience a residential intervention when that is the only way and the best way for them to get their clinical needs met. That it's not about a bed, it's about that's the best way to deliver those services and in the best interest of the child, and that it's short term. It's not a cost reduction strategy. We hope ultimately it will actually reduce costs, but that's not our primary goal. It aligns beautifully with Family First, and the qualified residential treatment programs should line up very nicely with our residential interventions. But we know at the end of the day, none of this works really well if Maryland doesn't simultaneously keep developing additional home and community-based services, evidence-based practices, mobile response and stabilization, peer support, intensive in-home services, and really high quality resource homes so that we can serve kids in their homes and communities. And we know it's going to be a big lift to shift to Medicaid reimbursement for providers, but we're going to be in it with them. So with that, I'm going to turn it back over to Liz.
Thank you, Deborah. So it's been an honor to work with Maryland as they work really hard to align strategies across multiple state divisions and departments to come to the same idea about what residential interventions are for young people, how they should be reimbursed, how they should be supported, and how the workforce should be developed. What we move to now is to a state that actually has done a lot of this work, and that's New Jersey. And also very honored to have worked in New Jersey on some of these reforms. But in order to understand it, it's really important to understand New Jersey's system of care sort of in a nutshell. And this is a slide that looks really confusing, but I'm just going to have you pay attention to the contracted systems administrator box in this. The contracted systems administrator in New Jersey is the single point of access in which any parent can pick up the phone, ask for help. We send it through a service called mobile response and stabilization. If necessary, we can get assessments completed. And the single point of access, which is currently under contract with Performed Care in New Jersey, has the capacity to help connect young people to high fidelity wraparound, which is where we begin the next part of our conversation. As I walk you through the services in New Jersey, you get to hear from some of the folks who are doing this work on the ground. So there's the contracted systems administrator, currently Performed Care, 24 hours a day, 7 days a week, 365 days, even through Superstorm Sandy. Performed Care answers the phone and gets help to people who ask for it. The care management organization is where high fidelity wraparound sits. These are independent nonprofit organizations that have two roles within the work in New Jersey. One is to facilitate high fidelity wraparound and to expand out the community resource development work. So in other words, they really are responsible for working with both the formal and informal supports that are so necessary for wraparound. There's mobile response and stabilization, which is another workshop for another day, and I hope you join us for that one. And then there's the family support organization, which is really where all this work begins. As parents help parents navigate and work through the system, they work through connections and coordination, and really are a big part of the work on the ground in shifting how communities think about and support young people. These are some of the other services within the service array, but the first part of that slide are really the core components of systems reform. So in the other core components, we have intensive in-home services, the residential interventions. There's a specific work around children with intellectual and developmental disabilities who are included in this conversation today. Substance use treatment, and then the formal traditional services like partial care, partial hospitalization, inpatient care, etc. I just want to talk real quick through evidence-based practices and how they sit. In New Jersey, there is the ability to connect to MST or multi-systemic therapy, functional family therapy, wraparound, and there's a large number of children who are connected to wraparound through those care management organizations in New Jersey, and then the nurtured heart approach. Before I hand it to Kathy, I just want to say what's really important in this conversation and what makes the residential interventions in New Jersey very different than other places around the country is that high fidelity wraparound, the care management organizations, both help coordinate the first parts of residential interventions through child family teams, which Kathy will talk a little bit more about, and help around the transition back home. So the engagement strategies that are so necessary, as we talked about earlier in the, in the role of the oversight agencies in ensuring that that happens. In New Jersey, we ensured that that happened through the care management organizations and making sure that those frontline care managers are really trained and skilled at helping families really understand what that residential is about and what we, and what their role is during the course of the full residential intervention. So now I'd like to hand to my former colleague, Kathy Collins, to share her work on the ground in New Jersey.
Hi, everybody. I'm from New Jersey, and I guess I feel lucky to be there from New Jersey, hearing all about how 20 years ago we started to do this. And we had the benefit of learning from a whole lot of other places that were ahead of us. And as you saw in Liz's chart, we're one of the core components of a system of care, but we have many partners in that. And we can go to the next one. Our CMO is called Monmouth Cares because our county is called Monmouth, and our mission is to facilitate positive change so that children with emotional and behavioral challenges, along with their families, have the greatest opportunity to live, thrive, and develop in their communities. That was our mission chosen by our board 20 years ago when we started. And in the past 20 years, we've added populations to our care management focus. We've added intellectual and developmentally disabled kids. We've added kids with substance use challenges, and we at Monmouth have added kids with chronic medical needs. All of these youth have an emotional or behavioral diagnosis, and then in addition, they have another complex need. If you just think of all the kids with the complex needs, they're probably in a CMO in New Jersey. The CMO is the local leader for the children's behavioral health, and we are county-based. So now, 20 years ago, we were the local leader, but no one knew that except us. So it took a long time before we were trusted, we were allowed in, even though I had worked in the county for 25, 30 years before I became the executive director. I was still treated very differently when I showed up at our county meetings as the CMO executive director. We do intensive care coordination using high fidelity wraparound. I know everyone on this in this webinar knows what that means. And we also do, and we are privileged to do this, it's a gift. We also do community resource development. And as part of that, and that's really focused, that's a focus on our mission to help change our communities, not just our children, because we want the communities to keep their kids at home, keep them out of trouble, and keep them in school. We don't want just right now we have over 900 kids. We don't want to just help 900 kids. We want to help all the kids in Monmouth County be able to live better lives despite any needs they might have. So part of what we did for community resource development was develop a resource net, which is a web-based a network of resources. And right now, to support our community's capacity, right now we have over 2,000 entries and we get 90,000 users a year, and we have 120,000 visits. So it's a very active tool that we can help all the residents of Monmouth County with locating resources. And right now we are at the center of a local system of care. With that means that every youth in New Jersey is covered by a system of care. The local systems of care look the exact same, the structure. They all have a CMO, they have mobile response and stabilization. We all have a family support organization, and you'll hear from one of them later. And we have the community providers and services, and we have the residential providers in that big group of providers. And we have county governance. We have a county council that serves an advisory role to the state about our local needs. Next. Every family that comes to us forms their child and family team. I'm getting ahead of myself here, or behind myself. This team stays with the youth and the family the whole time that they're in the CMO. And it's the mechanism by which all assessment and planning for youth and their family is accomplished. It's really the vehicle of all the change that happens, because all the energy is there, because it's all the participants or everybody that cares about that youth, whether they have a formal relationship or they have an informal relationship. And it's the way we say it is that the team is family driven and the care manager is the facilitator of the processes in the child and family team. It drives all care management activities, including services and interventions, and it has a structured membership, including formal and informal supports. And really what we like to know, or, I mean, the formal supports are often the ones you all know about: schools, juvenile justice, representatives, if the youth is involved in that system, providers. And the informal supports is we also sometimes call them natural supports. And our sort of rule of thumb is the bigger the team, the better the success. And so some of our teams might have 20, 25 people on them. Some have 2 because the family isn't sure about the process and doesn't quite trust the world yet to really get involved. So they're all very different. But our goal is to get as many natural informal supports in there, because that will allow the family to manage their own plan when the time comes for them not to need a CMO. The individual service plan is what gets developed by the team, and it's a strength-based, it's guided by the vision of the family, and it's a strength-based planning tool that takes into account the needs in 12 life domains for the family. It's individualized and strength-based, as I said, and residential intervention might be an intervention that is on the plan, but it is tied to specific articulated needs. It's not due to the failure of another system or service. It would be the team's job to fix that other service or that system, and not just the default to have the youth go to residential treatment. Next. So how is residential an intervention and not a destination? It used to be a destination 20 years ago. When we started, it had a lot of euphemistic names. A lot of times it was called the specialized boarding school. Sometimes it was just was a residential placement. Mostly it was about placement. And I remember 20 years ago, when we were getting to know our residential treatment providers, one of them said to me, "Our whole job is to re-socialize youth. It's to socialize youth in a sane environment." And of course, we know what that meant. That meant that kids stayed in residential for years and years. At that time, child welfare was, you had to give up custody of your child to have child welfare place them in one of these residentials. And child welfare, who was very overburdened, they felt the child is safe, we don't have to worry. And sometimes the youth were in there for years. It was also the way that they got paid. They got paid on a contract basis. So if they had an empty bed, they still got paid. So it was not in their interest to be discharging a lot of kids. So if we can have residential treatment that can ensure safety. And we're really talking about psychological and physical safety. And Liz covered that with the whole trauma involved needs that they come with that weren't really recognized back when they were the only sort of providers in town. With rapid stabilization, we can assume dysregulation and defensive fear in these kids when they come. And also the system is poised to reduce the length of stay in residentials as costly and as risky for kids. So there's a lot of pressure to do things quickly. So they better rapidly stabilize. They have to be expert in assessment and diagnosis, because the kids wouldn't be there if they were getting the really important and specific diagnoses that can be done when they are at a place with the intensive help of a residential, and high intensity and focused treatment, that they're not there for socialization to the residential. They're not there for behavior modification. They're there because we've already tried everything else, and then this is the best place for them to be, to get the kind of treatment that can be done when you have such intensive involvement with the youth. So what if we know, I mean, we do know now that our residential treatment facilities have all of these things, and you'll hear from one of them right after me. But if the child and family team decides that a residential intervention is called for, and the whole team led by the family decides that, then we would do an out-of-home referral, which is made to Perform Care. Perform Care is our ASO, and it is also does our Medicaid authorization. Every service in a CMO and in most other of the system of care is a Medicaid paid service. And how New Jersey covers so many kids with Medicaid is another story. But if you want to ask, we could probably answer that later. But if Perform Care as an authorizing agent, a clinical expert authorizing agent, agrees that an out-of-home referral is a good intervention for this youth, then a level of intensity is assigned, and that guides the child and family team in selecting the residential provider. There are right now 7 levels of intensity for behavioral health treatment, residential treatment. There are 2 for substance use, and there are 5 levels for intellectual and developmentally disabled youth. But all of these kids still have behavioral health needs. We do have some emergency stabilization beds, but that's a different system. This is really a planned residential intervention. It took years. I mean, what happens then is that the child and family team, Perform Care assigns a level of intensity, and then that opens up a kind of bulletin board where all the residential facilities that are at that level of intensity can see our youth and get access to all of the documents. And we then can also advocate for maybe 1 or 2 of them that we know better or would match with the youth or are geographically a better fit. And so there's a lot of negotiation that goes on. It's not an emergency. It's not an emergency placement. So it took years for all of this to develop, and families visit the residential treatment providers. The youth goes, and the youth has to agree, and they usually have a choice. Sometimes they don't have much of a choice because we get clogged up like most other system partners, and so sometimes the pressure is on to choose something. But if that child and family team does not agree with that residential intervention, then it doesn't happen. So there's a lot of negotiation with Perform Care, among team members, and among systems that are trying to help that youth. Next. What happens then is that whatever residential accepts, and the family has done a meet and greet, and everybody's in agreement, and it's very planful. The child and family team helps to add in all of the nuances that you need to hope that it's not a bad match or that it won't be successful. and the residential staff joins the child and family team. The child and family team does not step aside or go away. It starts to meet at the residential treatment facility, and the residential staff, they have a very big voice, because that's where the youth is getting their most help, but it's also within the context of all the other people on the child and family team. The child and family team continues to guide the identification of needs and the planning, coordination, the monitoring of care, and preserves the family and youth voice, because the family and the youth are in every one of their child and family team meetings. In the early days, the care manager would try to duplicate the child and family team work at the residential provider agency, but we were mostly kept on the bleachers. We were not really asked to join, the treatment team. We would sort of do our work along the edges, but that's part of growing. That's part of what a system has to achieve. But now we feel like we're full partners, and the individual service plan that's produced is a joint document. It's still the child and family team's document, but the residential planning and treatment activity gets attached to that plan. The residential intervention may not be effective or a good fit. We do follow the no reject, no eject principle of wraparound, and no, there is no emergency ejection. There's no going around the team like the olden days. Probation officers would call the judge, and the judge would violate the kid, and then the residential would have to. There's none of that anymore. There's a lot of pressure and a lot of negotiating that might go on, but the child family team changes the plan and implements it with the authorization help of Perform Care. Again, our Medicaid, our clinical Medicaid guidance that Perform Care gives us makes it a very thought out plan. And a new plan might mean a different residential provider or a community plan. Next. So this is really a summing up slide here. Residential is an intervention for the entire family now. They are all required to do family therapy. We're required as a care management organization to get the family there, or to make sure that they are included, or to help the residential entice the family into coming. And it can be a very valuable resource within a system of care, because it holds to the same values as the rest of us: strong family engagement, commitment to excellent and individualized care, and strong linkage to the youth's community. Intensive care coordination using wraparound with the dynamic child and family team can assure these components. We have even had residential treatment centers have staff, one you're going to hear about in a minute, but have staff, have staff follow the youth into the community as a bridge. And that has been really a wonderful experiment. So that's it for me.
Good afternoon, everyone. My name is Paul Rieger. I'm the CEO at Bonnie Bray. We're in Central Jersey. It's great to be here. It's also, this presentation is great. So Liz and Deborah gave you this overview, and Deborah's comments about being part of a system of care and not being able to have the residential intervention be effective without all these other parts is absolutely true. So it's great. Thank you, Kathy, kind of for setting us the stage there. I'll try to give a little bit of practically like what this looks like inside a residential with this change before I hand it over to Hazelyn for the family service organization. And that's what we really do. We view ourselves as part of a continuum, that our intervention is part of an intervention. We're not, just an intervention. And that includes what is going on with the youth and family before us, the other things that have happened. Kathy talked about some of the administrative things that happen too, which is great because it creates, when you're a residential provider, everything's, the child is coming. It's just a matter of which is the best place. There's a queue within Perform Care, which we get our referrals, and then we just start to get introduced to the family and the youth, see if it's a good fit, and then work through that. And on the other side, our community partners, the FSOs, the CMOs, all the other community-based services, we keep in touch with them so that we're able to transition the youth. So it's really about relations internally with staff, and having the opportunity, because of some of the other things that you've heard cleared up about child welfare, et cetera, that you're really hiring behavioral health staff and you're able to train them on the interventions that are related to trauma-informed care, self-regulation, et cetera, with the youth themselves, with the families, with the systems partners, and finally, our community partners. Next, please. So just a real quick snapshot of Bonnie Bray. We have a residential campus in central New Jersey, where we have 98 young men from the ages of 13 to 18. We have 3 community residential homes. 2 of them are 8-bed, 1 is 5. We're also opening a new crisis stabilization program for a 5-bed intervention real soon as well. We have a special education school on our grounds for the youth that have those needs. We provide other needs, including youth going to public schools for the youth that are able to do that. And we have community-based and aftercare services. As Kathy was talking, we're really focusing now on this point at how to this intervention, how to create that continuum so that the transition home or back into the community is really, really seamless, that we're part of it, that we stay part of it until the youth and family are okay with us handing it over or back over. There's a lot of work that's done with the families, if amenable and if appropriate, with family therapy, both during the residential intervention, but then can continue afterwards. Some of the other community-based services like the mobile response and IIC, there may have been therapists involved with the youth before that we can pass them on to. Next, please, Liz. So a little bit more about the New Jersey residential reforms and how that kind of escalated what we had already been doing at Bonnie Bray. So first, we'll talk about what we've been doing at Bonnie Bray. We did not have points and levels for many, many years, over 20 years. We also became Joint Commission accredited in the very late 90s. 1999 was our first Joint Commission survey, and we've been Joint Commission accredited ever since. And that started to drive us towards some of these performance improvement and quality assurance, including looking at restraints, seclusion and restraints. So we have over 20 years of data on that, and you'll see how that's interrelated as we move forward. And then we started to develop and overlay best practices and maybe even some evidence-based practices, life-based interviewing, motivational interviewing into our residential intervention. While Liz said before, residential intervention itself is not evidence-based, you can pull from other evidence-based and best practices depending on your population and those types of things to develop your treatment and your clinical departments further. But in 2015, the Children's System of Care applied for a SAMHSA grant. It was a system of care expansion grant to continue kind of the work that they had been doing for the past 15 years. Before that, Promising Pathways to Success was successfully granted to the state, and that ended up providing significant training, coaching, and structural changes within CSOC and within the provider network, CMOs, FSOs, et cetera, to help sustain this system of care long term. And this grant, pretty much looked at 3 separate areas to help do this. One was the trauma-informed care part of this, which parents, caregivers, providers, communities, needed to, be communicated to about trauma, the impact of trauma, and then also language that a trauma-informed care system of care would utilize. So CSOC took the lead on that. They engaged with Rutgers University to have trainings and continue that work out to get that information out to the state. Secondly, the six core strategy was a focus on helping reduce seclusion restraint in behavioral health settings. This is an evidence-based practice that that's designed for just that. Kevin Huckshorn the focus on preventing violence, trauma, and the use of seclusion and restraint. I'll talk about those 6 core strategies and just give you a couple of examples in those areas of how that helped Bonnie Bray during this time. So the first one is leadership towards organizational change. And when we looked at that as an agency and understood what we were getting into, we signed an attestation related to the Promising Pathways to Success grant that we would implement both the 6 core strategy and the nurtured heart approach. And the leadership towards organizational change really started even at our board level, where we would even break down restraints and show the data related to them to the board. I think one of the things that was helpful in this is the board became much more, learned a lot more about what we actually did at Bonnie Bray and what was going on. And that energized them. I think it even energized philanthropy actually too, because they really started to understand what these young people and families were challenged against. And then we added a youth to the board. We added a parent to the board, people that grew up in other parts of the system to the board, really to escalate that. And while these things sound hard or challenging, or like, how do you do that? It's amazing once you start doing it, that how easily that happens and what a big change that makes. Using data to inform practice is the second core strategy. I'll talk about restraints, I guess, with this one. I said before, we had about 20 years of data on restraints. We were kind of just looking at that, right? Like how many do we have? When do we have them? Which youth have them? We really started to break that down and, looking at it from a trauma-informed lens individually, and really started to break that down and think about that and think about becoming a restraint-free agency. And we talked at first about reducing restraints, but now we're able to say that our goal is to be able to be restraint-free. When I started here in 2016, we were averaging over 3 restraints a day. We just went through the last 90 days with 1 restraint. So it's really, really changing significantly. That takes some time, but the 6 core strategies and the nurtured heart approach, everybody starting to speak that language. From the beginning, it's like, we're not going to do restraints anymore. People started to, without the tools that the nurtured heart gives you and some of the trainings from Rutgers gives you, you're left in a space where you're not de-escalating kids or giving them the tools to self-regulate, et cetera, and you might get yourself in trouble. That's why it's really important to have some overlaid evidence base and best practice approaches to help you with that. Developing your workforce, Liz was preaching about that before, being able to train your workforce, bring your workforce in, educate your workforce, give them opportunities to continue their education. This system redesign and the financing part and what we didn't have to do and what we could focus on enabled us to spend a lot more time doing that. So, right now, for example, I have 5 men, actually Black men, that have been with me for over 10 years here at Bonnie Bray, and they're all in master's programs, master's social work and counseling. So it really bodes well for the future of leadership and development of staff. And they're still all in the residential milieu, working either as supervisors or directors. So being able to transfer those skills within the cottages when we go out in the community, et cetera, is great. Fourth, developing seclusion restraint prevention tools. A lot of that revolves around trauma-informed care, creating that environment, full inclusion of youth and families. Again, in that process, I'll talk about that next a little bit, about how to engage youth in the communities and within the community of both the residential intervention and then the larger community. And families, again, from the beginning, they're part of the decision. They are part of the team. They can come visit. We invite them to visit. We have family time both here and at the youth's homes. That works out really, really well. And then finally, rigorous debriefing. So again, our example of this is every Friday still, if we have a restraint or any type of unusual incident report or something that may even positive incident reports where we may have seen see a situation that staff did really well or a youth did really well to avoid a situation, or one youth helped another. We review all of those as a team and look at what we can learn from those. So that's kind of the 6 core strategy. In a nutshell, nurtured heart approach across the state of New Jersey, right? People are trained in the CMOs, in the residential interventions, families, schools now are being trained as the Promising Pathways 2.0 is out. And it's, Howard Glasser, and it's a method really that helps adults learn how to intervene, focusing on positive energy for youth with challenging behaviors. For us, it has resulted in certified trainers. The certified trainers do part of new hire orientation, which is several hours on the nurtured heart approach. So it's a really good model that everyone, again, across New Jersey is able to speak. Just a real quick story about how that played in. Our crisis team in the school last year worked on this really hard. Actually, out in the COVID year is always kind of blank too. So it was actually the year before that too. But the crisis team in the school, they were looking at their interventions, and when youth were having problems, transition to school, time during the school day, which youth, et cetera. Sometimes there ended up in restraints, other types of violence or damage, et cetera. And through this nurtured apart approach, they looked at this deeper within themselves and with the youth. They worked, and even in talking to some of the families, and what they really saw was our crisis team is made up of mostly men. The teachers are mostly women and mostly white. Our youth are mostly Black and brown, and so is the crisis team. And the youth, the young boys that we had here, they really wanted to just spend some time with the crisis staff. So what they did is they created a breakfast every Thursday morning where they would have youth come to that, and they developed, again, like we talked about at the beginning, they developed their relationships to a deeper level, not just, oh, if I do this, then I get to go see Mr. Kelly in crisis. 75% reduction in restraints in 1 year. So again, these tools, taking practical, applicable approaches with them, really, really make a big difference. Okay, Liz, you can go to the next slide. Thanks. So youth and family voice, we talked about that, quite a bit. And I mentioned about the board, having youth and family on our board. We also are hiring, developing, whether it's therapists, some childcare staff that have had experience in the system, but the youth that come to us and the families that come to us, it starts, pre-admission. It already started, as you heard, with the CMOs, and then we take, we get connected in with that as well. We have, in pre-COVID, we'd have tours and have the youth and families come here to really make sure that this was part of their choice. They could ask questions. Now we do a lot of that virtually. They can see where they're going to live, ask questions, tell us a little bit of their trauma story. We learn about what their favorite meals are, what their favorite sports teams, so that their environment here is then set up. When you see a youth smile on their first day at admission to a residential treatment center because their room has a New York Yankee banner and they're getting pizza for dinner, it really does. It really is a big effect. It really changes the game as far as moving forward. And then they have FaceTime the first night with their family, make sure they get introduced to the cottage staff. And this is everybody's job at Bonnie Bray. We have a culture, we like to describe it as a culture of caring that's very strength-based. And every single person on the team, whether the family or youth bonds with the nurse or the kitchen staff, we have a dietitian, or the therapist, or one of the child care counselors in their cottage, whoever that is, they have access to that person. And that we really have helped help us define and redefine them having their voice, because they have to be comfortable. They have to learn, they have to trust, and they pick those people out on their own as we move. So as we move from admission through aftercare, we keep that in mind as far as the youth and family voice. I said before, New Jersey has intensive in-home counseling services on the Medicaid platform to do family counseling and individual counseling for youth as they transition out. We've done some self-funded aftercare with some mentoring. With that, we our outcome studies. So another thing that we've done as related as far back as the Joint Commission started was outcome studies. We do them 3 months, 6 months, 1 year, and then 3 years afterwards. And what we saw in those outcome studies, and it's still true today, is that success during that time after they leave, or this part of the intervention ends, is predicated on them having at least one strong adult caregiver in their life, that they're connected either with education or workforce, and that if they found something while they were in the residential intervention or otherwise that they're interested in, whether it be music, sports, we can call them affinity groups, some type of art, photography, et cetera. If they're doing those things, those 3 things, the likelihood of success really, really increases. Liz, you can go to the next one. So for community engagement, we have several areas. Our ambassador group is a group that does, it's kind of like our youth council. So they provide leadership, they provide feedback to the residential department. They also do things like sit in on interviews and man the front desk at times. They're the representatives to the community. For volunteer work, we do a bunch of different things. Some of the top ones are going into New York City to feed the homeless through the Bridges Outreach Program. I participate in a 5K, the Tunnels to Towers, a 9/11 event. Our Bray builders have built over 50 homes connected with the Morris Habitat for Humanity. So youth are in the community, working with regular people, doing some service and learning to give back, but also maybe developing some life skills. Some of those youth in the Bray Builders, for example, have gone on. We just got had to do a reference for a youth who's on Long Island joining the Carpenters Union. So again, getting youth in the community, engaging them. We have a drum corps, we play AAU hoops and do all those things, but they get to experience some things, maybe either things that they've done already or some things they'd like to do and important when they move back. So that's our community engagement. So the other book on this, I'm going to turn it over to Hazelyn and let her talk about the FSO.
Good afternoon, everyone. I'm delighted to be here. I'm from Family Support Organization of Essex County, and we're one of 15 family support organizations across the state of New Jersey. I've been privileged to work here for the last 16 years, so I've seen the unfolding of some of the systemic changes that Kathy and Liz and others have spoken about. One of the things I'd like to say about our organization is this: what makes us unique is the fact that we are family-led. From our very board, which is 80% family members with lived experience within the children's system of care, to the volunteers. We provide peer support, education, and advocacy for youth and families who are receiving CMO services with the simple goal of working toward creating an environment in which they can thrive. And that is our core mission. When it comes to, next slide, please, how we do our work, we receive our referrals at the same time as they are open to the CMO and perform care. And we collaborate very closely with the care management organization in going out on that initial visit to introduce the services as system partners. And that has proven to be very effective for us. We've seen an increase in engagement when we present in that collaborative fashion. The core provider of the peer support service is the family partner. While we have 3 specific positions that work with youth and families, the family partner is really at the center. And I'll speak just briefly about the other 2 before I go on further. The other 2 positions are the community engagement coordinator, and they collaborate very closely with the care management, community resource development staff, and others to find and implement programs and activities across our local community that strengthen families. The other position that's absolutely critical in this conversation is the youth coach. And this is a program, the youth coach is responsible for developing a peer-led group of youth leaders who have the mission of working within the community to educate professionals and peers and reduce the stigma that's associated with some of the challenges that our youth have. So I just wanted to acknowledge those other parts of our system that are very important. Now back to the family partner role. The family partner is a person with lived experience. Yes, we all come with different academic backgrounds. You may have a social work degree, a law degree, you may have been a special education teacher. But the one thing that unites us is the fact that we are MOMs and DADs, okay? We have that lived experience of raising a child with significant challenges, moderate to severe, that place them at risk of being out of home. And so when we work with families, we bring that lived experience into the conversation from day one. Our core mission is to help them thrive. And we do that by really demonstrating empathy, using active listening skills, helping them to tease out, like, what are some of the options? Oftentimes when families come to us, they feel frustrated because they've tried a lot of different things and they haven't worked. There may be conflict within the family where they're unable to really come to a consensus around a vision or a plan of action. And our goal is to help them with that. And to do that, we use something called the Family Assessment of Needs and Strengths, which is a tool that's complementary to the Strength and Needs Assessment that's done by the Care Management Organization, and also the other tools that are used in other parts of the system. They all work together synergistically. I wanted to share, you can go to the next slide, please. Some of the things that family partners do and are able to do because of that lived experience is to engage more quickly. There's something about being a credible witness, somebody that says, I understand where you have been. My journey may look different. It may not have all the nuances that yours has, but there's some similarities, and we leverage that when we speak with parents. And what we typically hear is, I thought I was the only one. And we're able to share with them, you don't have to do this alone. We're here to help you navigate this maze of services that, sounds very confusing initially. And we're here to help you through that. We offer hope to parents, and we serve as a witness that change is possible, and that it is possible to overcome some of the current challenges and thrive despite them. When you've been in a position like this for a while, you get to see some success stories. And recently we were invited to the college graduation of one of our youth who had been in the system of care for many years, multiple systems. And this young lady has now completed her bachelor's and will probably be going on to do a master's in social work. But that's because we were able to connect with that grandparent in an authentic way, match her to a grandparent who was also raising children with challenges. And that relationship gave her hope. It also gave her what she called a tool belt that she could use to educate her family, to build a team, a network of supports. You heard Kathy talk about natural supports. That's central. And also to connect with other parents who became her supportive community, okay? One of the other things that we can do in terms of the residential experience is to explain the processes before, during, and after placement. One thing I'd like to say is that when parents come to us and they're thinking about residential placement or intervention, they are really scared. They're confused. They may be conflicted, and they also may be at the level of enough. I just need to change, stop the pain, okay? And so it's our task and our privilege to be able to walk alongside them and explain some of the processes. Sometimes they may have questions about the finances and how is this going to work? And am I going to end up with a big bill and having to pay back something? Or they may have questions about policies regarding visitation and how that will work, sibling involvement. So we're able to sit as a formal part of the child and family team and help the parent understand some of these things. And we make ourselves available, especially during that decision-making time. And once the intervention is agreed upon and the youth is now in placement, there's a continuous relationship between the family partner and the parent to help them through these different phases. One of the things I share with my team is that we like to begin with the end in mind, meaning just like when you go into a hospital, discharge planning begins almost the day you arrive, right? Once you know what you're working with and what the intervention is going to be, you begin thinking about what is it going to look like when we leave. And that's one of the things that we really focus on with our family partners, is helping them to keep that parent engaged in building their network of support, building their inner wealth. We use the nurtured heart approach and have for over a decade now with parents to help them develop that inner wealth so that they're better able to cope with and manage the difficulties of having a child with challenges. We help them to anticipate what might be coming. So a great deal of our time is now focused on, okay, if you have a youth that's out of the home, how are you preparing to implement some of the same strategies that have been used within the residential setting when that youth comes home? So we're now running Nurtured Heart trainings along with our system partners. We have run a Nurtured Heart training just recently. We had great participation and consistency over the weeks. And now we're launching Nurtured Heart support groups where the parents get together and talk about the strategies that they've used and how they're implementing them within their homes. We also use other methodologies, some community education resources to help people understand the educational system and their rights and responsibilities, how to navigate that. And the main goal is really to connect parents to parents so that when formal services end, they have created lasting relationships in their communities with people who will be with them long after we've gone. Another part of the work is really helping families to understand and manage the complex feelings that they have. The parent may have been impacted by violence within the home and may be really struggling to stay engaged. And so in situations like that, we help the parent to understand what may be going on with the youth and help them to think about strategies that they can use to build coping and resilience skills to be able to continue to have a relationship with that youth, even if residential permanency is not going to happen. There's situations in which the youth may not return home. They may be 19. The youth and family may decide this youth is not coming back here, but there can always be relationship. There can always be relational permanency. So that's what we kind of focus on with parents in that situation. We aim to also model effective parent-professional collaboration for parents. I know that none of you have ever encountered a parent who was irate and had a difficult time communicating effectively what they needed and wanted. So that's where our family partners are hopefully well trained to help model the behavior that's necessary so that their voices can be heard. Because one of the central tenets of this whole body of work is the importance of family voice and choice. Okay. Factors that lead to success. I mentioned that our board and staff and volunteers are all family members. That's a big part of who we are and what we do. That's part of our identity. And the policy here is that everyone participates in wraparound training, child family team training, even Nurtured Heart training, and that includes our board members. We see family engagement as everyone's responsibility, not just the family partner. It's a shared responsibility for everyone on the team. And so increasingly, we find that to be something that's being realized in our community and has tremendous benefit. Then we also participate in running trainings with our system partner to facilitate family engagement and peer support at different levels. And the last thing is that we definitely participate in work groups, committees, and governing bodies, and help families to participate in those activities, because that's another area in which their voices can be heard. So there was a mention of a county-based committee, the Children's Interagency Coordinating Council, in which family members participate in giving input on plans and policies that affect the lives of the children and families that we serve. Our philosophy is this: nothing about us without us. And families, in the final analysis, that's where the story begins for all of us. And that's where our stories end. And I'm just happy to be able to do this work and to share this experience with you.
All right, everyone, thank you so much. We have time for just one question. And for those of you who put something in the chat that we won't have time to discuss today, we'll do our best to follow up by email with you. So rest assured, we will try to get to your questions offline, so to speak. While you pull up that link in the chat about the evaluation, I'm going to get to this one question. How did New Jersey get the integration to happen between the CMOs and the residential providers, such as the shared service plans, or the shift to using the child and family team for all decisions about moves? Did it start as a regulation shift or a culture shift?
I'll take that one. So it's all of that, right? So it has to start with culture. We have to shift language. We have to shift our understanding of the table. In other words, we need to level the table so that parents and youth not only have a seat at those tables in the decision-making, but also are driving those decision-making. But you also have to address the financing of how services get paid for, so that what we didn't talk about is that every child, regardless of whether they have Medicaid or commercial insurance plans, they have access to the same service array and the same planning, and we figure out all the finances in the back door. And the third component is connecting the dots around what partners can do, right? So New Jersey is fortunate to have a single electronic record that's shared across all provider organizations, where all the documentation is kept, so families only have to tell their story once, that there's consistency in terms of the documentation and how it's shared and communicated, but also there's a payment mechanism that says, because the state has said that the child family team is the driver of the decision making, that we don't make any decisions without families at the table. And because of that, the child family team makes the decision about who gets paid and how that works through prior authorizations that's connected to an individual service plan. So it's both a philosophical and a functional way of getting the work done. If you have further questions, I'm certainly happy to answer them around both this systems and any other systems regarding residential interventions.
Yes, I apologize that our Q&A was so brief today, but I do want to thank our outstanding presenters, Elizabeth Manley, Deborah Harberger, Kathy Collins, Hazelyn Pilgrim, Paul Rieger, for sharing their experience and strategies with us today. And thank you to our interpreters, Jessica and Henry. And thanks to you all for joining us for this segment of Training Institutes Live. If you haven't registered for one of the 3 workshops beginning at 3:30, it is not too late. The registration links are in the chat. We would appreciate you taking just a few moments to complete the evaluation for this workshop using the link that is posted in the chat. We take your feedback seriously, and it will help us to shape our upcoming series. As a reminder this summer, take us whenever and wherever you go. July and August workshops will be released the first week of each month and available to you all month long. Listen and learn to select workshops of your choosing, or listen to them all. The link to the workshops on the website is also posted in the chat. So again, thank you for joining us today, and we look forward to seeing